I'd like to thank Kozhikode Ophthalmic Society as well as Dr. Sujit Nayanar and the President for giving me this opportunity. This is a very special occasion for me to present this delivery of the scleritis. Let me share my slides first. Is my slide seen?
Yes, sir.
Okay, am I audible?
Yes, sir, very much.
Okay. So, as I told you, it's a very special occasion for me. Down memory lane, 39 years ago, one housed up in regional ophthalmic hospital in Calcutta saw a case of necrotizing scleritis in a patient with rheumatoid arthritis with his teacher. Teacher name was Professor S.C. Shen. That young man was asked to present the case in the monthly ophthalmological meeting at Calcutta. That was his first scientific presentation. And this one. And this was the slide which I presented. Those days, the PowerPoint slides also was not there. And this was the handwritten slides which I prepared. And this was me 39 years ago. I dedicate my presentations to the loving memory of my teacher, late Professor S.C. Shen, who gave me the first opportunity to present a scientific presentation. This was my teacher, Professor S.C. Shen. I dedicate my talk, keynote address in the memory of my teacher. Sclera, what is special in the sclera? It covers 5/6 of the circumference of the globe, but it doesn't attract that much of attention. It is composed of collagen and elastic tissue, transmit blood vessels, but retains very scanty supply. It has got a low metabolic demand, gets nutrition through the episclera and underlying choroid. Affected by the collagen disease like granulomatous inflammation, autoimmune process like Wegener's granulomatosis, etc. So it is one of the differential diagnoses, as Dr. Sujit was telling, is the red eye, and it comes with a dull, boring, aching pain, significant redness, systemic complaints. Some of them have decreased visual acuity. Systemic history sometimes is positive, and investigations also can be productive in such cases. And systemic medications, including corticosteroids, immunosuppressive agents has been found to be beneficial. I'm not going into the details of how to differentiate acute conjunctivitis, episcleritis, scleritis, acute iridocyclitis, or acute angle closure glaucoma. I'll be showing one or two cases to show that how an anterior scleritis or posterior scleritis presents. Little bit basic. This is a Watson-Harris classification, which is a quite age-old classification. Shonsing-Harris from India, both of them were Moorfields, brought out this classification. Scleritis is divided into two parts, anterior and posterior. Anterior is further classified into the diffuse, nodular, necrotizing. Necrotizing can be with inflammation, the necrotizing scleritis, and without inflammation. Actually, it's not without inflammation, but inflammation is clinically not evident. That's a scleromalacia. So this is the various types of scleritis we encounter. I'm not going into the details. I will show each of them as the talk goes on. There can be really a serious complications like corneal involvement, scleral rupture, scleral perforation, and scleral thinning, significant scleral thinning. So today I'm going, as told, as I will be talking about non-infectious scleritis. I will not touch upon the management. I'll talk about the investigations a little bit. Scleritis and episcleritis, as you know, are the inflammation of the outer coat of the eye, but have varied characteristics. And you can see this simple diagram show the normal, and in episcleritis, that superficial episcleral vessels are bored up, and deep scleral vessels are bored up, as well as the superficial episcleral plexus is bored up. In case of scleritis, there is a scleral edema is noted. So episcleritis is benign inflammation of the episcleral tissue. It doesn't cause permanent structural damage and mostly unassociated with systemic disease, except some hypersensitivity to the tuberculosis. Whereas the scleritis is other side of the coin, can cause visual impairment, produces permanent structural changes, and often associated, which is very important, with a serious systemic disease or autoimmune process. This can involve the adjacent structure, as this slide shows that the cornea, peripheral cornea is involved, sclerokeratitis, or it can be sclerouveitis. So all cases of scleritis, apart from the torchlight examination, you need to see in the slit lamp for evidence of anterior uveitis. Anterior scleritis is up to the ora serrata. Posterior scleritis is beyond the ora serrata. These are the two different anatomical division. But there is some people called panscleritis. Both anterior and posterior segment, posterior sclera is involved. So in the examination, external examination of the eye in daylight is often advisable, but it's not practical. Episcleritis will give a salmon pink appearance. Scleritis color itself is different, deep purple, and scleral thinning is better visible in the daylight examination. Slit lamp examination, you should do the diffuse illumination and red-free light. Scleritis should show scleral edema and congestion of the deep episcleral vessels. The avascular patch, if we see in close examination with the slit lamp, that indicates poor prognosis. Necrotizing process has started, and the corneal changes you can see. This is the red-free illumination, which will stands out the deep episcleral vessel congestion. So if you do a phenylephrine test, constriction of the conjunctival and superficial episcleral vessels are done, the constriction occurs, and the deep scleral plexus becomes prominent. So many of the patients says that I have got redness, I got redness, and when you come to the examination, slit lamp examination, you would not find anything. So this indicates that the patient probably have superficial episcleritis. This is the before 10% phenylephrine test with the episcleritis component and scleritis component is there. Episcleritis component goes off after the 10% phenylephrine application, and the deep scleral vessels becomes prominent. How the scleritis present is almost always painful except scleromalacia. Typically dull boring pain, radiate to the ear, scalp, forehead, and exacerbates by eye movement. Worsens at night, typically waking up in the patients from the sleep in the early hours of the morning, and they do not respond to the usual analgesic like paracetamol, etc. 17% patient posterior scleritis may be asymptomatic. So posterior scleritis is often difficult to diagnose. They can have pain on movements of the globe, but 17% of the patients may be asymptomatic. Diffuse and nodular scleritis comes with a sign of scleral edema and congestion of the deep episcleral vessels. And here the schematic diagram shows that the deep episcleral vessels are elevated, and there is a scleral edema, and superficial episcleral vessels is also congested. There is no watertight barrier between the superficial sclera and the deep sclera. This is a diffuse anterior scleritis. It almost comes about 30 to 40% of the cases, most common type of the scleritis. And if you look carefully, you can see the dilated deep episcleral vessels. As you've seen that the diffuse dilated deep scleral vessels are seen. And this is nodular scleritis and can have one single nodule, which is more common, but can have multiple nodules as shown in this picture. Necrotizing scleritis, rare but severe form of scleritis. And there is a scleral thinning, uveal show is seen, and they can be dangerous, can lead to the perforation of the sclera, and can even the uveal tissue can prolapse out. And this can be really is alarming. Scleromalacia is the extensive scleral thinning, and sometimes uveal staphyloma is seen. These are the few examples of scleromalacia, usually associated with the long-standing rheumatoid arthritis. This is another picture of scleromalacia, and you can see the uveal tissue is bulging. Scleritis and systemic disease is the most important aspect. 50% of the scleritis is associated with the systemic disease. Systemic disease varies with the clinical subtypes. Posterior scleritis have less systemic association. And I feel it's indeed a crime not to investigate for systemic disease in scleritis. The most common systemic disease associated with scleritis is rheumatoid arthritis, followed by granulomatosis with polyangiitis, earlier known as the Wegener's granulomatosis. You know that why Wegener's name was removed, because he was a Nazi. Relapsing polychondritis, polyarthritis nodosa, systemic lupus erythematosa. This is a picture together with the scleritis. I took the picture of the rheumatoid arthritis. You can see that same picture. The patient is having rheumatoid arthritis as well as declarizing scleritis. Rheumatoid arthritis and scleritis, about 20% of the scleritis will have rheumatoid arthritis, which is one of the most common association. But if you look at the rheumatoid arthritis, 0.2 to 6.3% will have scleritis. A lot of the rheumatoid arthritis patients do not have scleritis. Granulomatosis polyangiitis, that was earlier known as the Wegener's granulomatosis, most common cause of vasculitis associated scleritis, more severe presentation, more aggressive case, and can be localized form of granulomatous polyangiitis. And this is limited to the eye only. Scleritis and relapsing polychondritis can be bilateral, nodular, diffuse, and necrotizing. Scleritis and SLE, I have not seen a single case, but uncommon but severe complication of SLE can be diffuse, nodular, or posterior scleritis, rarely necrotizing. Drug-induced scleritis for completion is very uncommon. Biphosphonate is known to cause drug-induced scleritis. Even the mood-elevated drug, methamphetamine, also can cause scleritis. Surgically induced necrotizing scleritis is one of the dreadful scleritis form, and nowadays it has become increasingly rare. After pterygium excision is quite common. Cataract extraction, trabeculectomy, penetrating keratoplasty, strabismus surgery, retinal detachment repair, and it's a rare complication. But the name appears to me as a little difficult for me to adjust, because I had a patient of surgically induced necrotizing scleritis. I give the case summary in the patient's hand, and patient was a lawyer. He sued the doctor because he said that is a surgically induced scleritis he has produced. So this term may need to be probably taken with caution. Posterior scleritis, as Watson put it, that one must be one of the most underdiagnosed treatable condition in ophthalmology, partly because its manifestations are so protean, and partly because the diagnosis is rarely considered, and it doesn't have the kind of classic features. They can have folds in the or stria in the posterior pole, or can have nodules, and these nodules can be seen on ultrasonography and can have complete T sign or partial T sign, showing with high surface and low internal reflectivity is seen in the swelling. This is one of the case called giant nodular posterior scleritis. This is a 50-year-old female with pain on movements of the globe, but if you look at the FFA, is showed that the diffuse hyperfluorescence in the late stage. What is very important is that ultrasound can be made, can clinch the diagnosis in such cases. And they respond to oral steroid. It melts actually with oral steroid. And you can see that from the nodules has completely disappeared. And you don't see trace of it. This is called giant nodular posterior scleritis, rare condition, often mistaken for an intraocular tumor, especially amelanotic choroidal melanoma, choroidal hemangioma, or metastatic tumor. As we told you, ultrasonography clinches the diagnosis. It will show that T signs and sclerochoroidal thickening. Good response to systemic steroid is the hallmark. Posterior scleritis is often idiopathic. Systemic association up to 28% cases is seen. Now I'll show a case of anterior scleritis, which I have faced, and this is a very challenging case. 33-year-old male, pain and redness in the left eye, joint pain, cough with hemoptysis, low-grade fever. But when he came with the necrotizing scleritis with uveal prolapse. I did the investigation. It came ESR 114 millimeter per hour. I was really surprised. I didn't see an weakness before. MANTU was negative, RA factor, and C ANCA was positive. Urine analysis was abnormal. When I looked into the posterior segment, I could find out the retinitis, peripheral retinitis with exudative retinal detachment. And his chest X-ray showed cavity in both lungs. In fact, he was getting treatment for tuberculosis. The pulmonologist thought that it's a tuberculosis and getting treatment for the same. So bronchoalveolar lavage was done, and which was Pseudomonas was positive, AFB was positive. He was started on tablet metronidazole and injection garamycin. That time it was available, and topical steroid and antibiotic. But in a few days, 4 days later, the things changes. Palpable purpura on the hand and feet. Blood urea was 47 milligram. Serum creatinine was 4 milligram. And progressive retinitis roaching towards the posterior pole. And at that time, the renal biopsy was done, and it showed crescentic glomerulonephritis. C ANCA was positive. Cavities were seen on CT scan, and ultrasound guided aspiration from the lung cavity showed hemorrhagic and sterile pus. So treatment, we need to do dialysis, IV methylprednisolone for 3 days, pulse intravenous cyclophosphamide, followed by the oral cyclophosphamide 50 milligram, 1 tablet 2 times daily, topical steroid, topical antibiotic. Scleral graft was advised once systemic conditions removed. And in fact, it did well. Is that uveal prolapse was covered by fibrous tissue, peripheral corneal ulceration was healing, retinitis resolved, disappearance of the purpura lesion, and 1 year after, you can see that there is a dramatic improvement. Patient was well, but systemically patient did not do well. Patient died due to the systemic complications after 1 year, in spite of the treatment. Now another case of, this is a 43-year-old female with dimness of vision for 6 months, occasional pain, redness and watering, right-sided headache. Patient was on oral steroid. Symptoms have improved, but when I looked into the fundus, I could see the stria on the fundus. And this was more evident on the red tree. You can see that. And this was actually a posterior scleritis. T sign was found to be positive here. And CT scan was done in those days in the posterior scleritis. You don't need it. In the posterior sclera was thickened. So posterior scleritis can be confused with metastatic tumor, amyloidotic melanoma, pseudotumor, and posterior uveitis. This was not my slide. It is a case I was enucleated in the suspicion of tumor. And you can see that the posterior sclera is thickened, which gives that impression of the tumor. This is the posterior sclera, thickened posterior sclera. General examination is quite important, as I told you. It is associated with many serious systemic disease. Joints, cardiovascular system, skin has to be looked carefully for relapsing polychondritis, rheumatoid arthritis, systemic lupus erythematosus. Episcleritis, as I told you earlier, it has got associated with atopy, erythema nodosum, contact dermatitis, tuberculosis, which is not much significance. You don't need to treat for that. But scleritis can be associated with the collagen vascular disease, inflammatory bowel disease, gout, and others. Scleritis and Wegener's granulomatosis is often very challenging, can lead to the perforations and often require, sometimes requires a scleral patch graft. I'm not going into the anything of management, which is be dealt by Dr. Somshila. Why should you look for systemic disease in scleritis? Because the scleritis can be the initial manifestation of unexpected systemic disease. I do have many patients of 30 years follow-up of uveitis, choroiditis, etc. But I don't have many patients of necrotizing scleritis, which is coming 30 years or 40 years. I think that's maybe the some of the patients may succumb to systemic disease which they are having. Aggressive therapy may be required not only to save the eye, but also the patient's life. Episcleritis, I don't investigate at all. Scleritis, two things I do. One is the rheumatoid factor. Another is the ANCA, anti-neutrophilic cytoplasmic antibody. I don't forget to do it. Others is the TLC, ASR, C-reactive protein, MANTU, and rule out syphilis. As you know, it can mimic all type of disease, inflammatory diseases. Scleritis complications, 70% of the patients can have complications. Elevated IOP, 40% of the patients. Cataract, up to 50% of the patients. So ancillary test, I will be touching on it. Anterior segment OCT, ultrasound B scan, which I shown you on posterior scleritis, ultrasound biomicroscopy, CT scan of the eye and orbit to rule out pseudotumor. UVM in scleritis, I was working on scleritis, can detect the extent and degree of damage caused by the scleritis, can help in planning the therapy. This was presented in the 2020 years back. I was doing ultrasound biomicroscopy. I was presenting in the Argentina this then one of the people is saying, why are doing ultrasound biomicroscopy? Although already the sclera is, the patient is having pain due to the sclera and you are putting the probe over there. So I reduced my doing the ultrasound biomicroscopy. You can, if you do it, then you can see the scleral edema and scleral thickening. And the ciliary body edema can also be picked up by ultrasound biomicroscopy. Cyst can be seen, interscleral blave, and calcification. I end up with a case with a scleritis case. This is a 47-year-old male with 2 months. Nowadays, I do the anterior segment examination, ASOCT I do instead of UVM. Now I show a patient, which is a challenging case, 42-year-old male with 2 months history of pain, swelling, and redness, was suspected as a scleral tumor. He was referred to us for brachytherapy. And we did the ultrasound, the one, no intraocular extension. Scleral coat was only thickened. UVM showed homogeneous mass arising from the episcleral sclera. I just show the picture again. This is a mass lesion. Do you think is a collagen disease-induced scleritis? So we did the routine investigations. Nodular scleritis, the patient was asymptomatic, major systemic illness, and see what we got. RA factor negative, ANA negative, VDRL and RPR and TPHA was positive. When the patient was put on benzathine penicillin intravenous, and then this showed complete resolution. So it is a nodular syphilitic scleritis masquerading as ocular tumor. We published this case. So in summary, that scleritis, don't think so simple. Always investigate. Get a checkup by a physician, preferably by a rheumatologist, and keep the posterior scleritis in any posterior segment involvement where you don't see, like except choroiditis cases, you should keep the posterior scleritis in mind because it has got protein manifestation. Thank you very much. So I thank again Dr. Sujit and Kozhikode Ophthalmic Society for giving me this opportunity to pay respect to my teacher, Professor S. Shen, with whom I presented my first talk in my life as an ophthalmologist, scleritis. Thank you very much. I stop sharing.
Thank you, sir. Thank you, sir, for that exhaustive talk. I think a lot of points have been, new points also we've got from here. So we'll come to the questions, sir. There's one question from Dr. Meher. Do you fully investigate for systemic causes at the first episode of scleritis?
So I do investigate. Every case of scleritis, I do investigate. I do that, as I told you, the lab investigations, and I definitely send it to the rheumatologist to all the cases, even except episcleritis. Scleritis always do,
Thank you, sir.
particularly necrotizing scleritis, for sure.
Yeah, that needs a systemic workup, complete workup.
Yeah.
And also a rheumatologist opinion also.
Yeah.
At this point, I want to welcome Dr. Anup, consultant rheumatologist, who has joined us. Welcome, sir. This was, sir, have you seen a case of drug-induced scleritis in your practice?
No.
Any of the other panelists have seen? Dr. Somshela, Dr. M. Vanati?
I have not yet come across drug-induced scleritis so far. Maybe Soms should have seen more, I guess.
So me neither. There was nothing that we could conclusively prove that it is drug-induced, so I have not seen any.
So, right now, there are no questions. So can we go to the next talk? We'll come back to you, sir.
Yes, sir. Yes, ma'am.
Thank you, sir. Thank you so much. Dr. Mahir?
Yeah. Thank you, Dr. Biswas, for that wonderful talk. So our next talk is about an equally important topic, infectious scleritis, by Dr. M. Vanati. Dr. Vanati did her post-graduation in ophthalmology from RP Center, All India Institute of Medical Sciences. She did her residency training in cornea, contact lens, eye banking, cataract and refractive surgery from RP Center. She has also obtained an international fellowship in corneal lamella surgery from Singapore National Eye Center. She has over 95 international index publications and numerous chapters in international ophthalmology books to her credit. She is currently working as Professor of Ophthalmology, Cornea, Cataract and Refractive Surgery Services at RP Center. I invite Dr. Vanati to give her talk on infectious scleritis, clinical presentations and diagnostic science.
Thank you, Dr. Meher, for for the nice introduction. And I should thank at the outset both Dr. Vijayalakshmi and Dr. Sujit for having me on this wonderful academic session. Infectious scleritis is something which is rarely discussed in depth. Scleritis per se itself is rarely discussed. So I'm going to limit myself for the next 15 minutes or so to the various looks of infectious scleritis, focusing per se on clinical presentation and the various diagnostic signs here. I do not have any financial interests in the mention of any products or procedures during the course of this talk here. I might have a little overlap to what Dr. Biswas explained to us earlier. That was a very exhaustive and a very lovely talk which he had presented. So when you're looking at infectious keratitis, you're going to look at what are the organisms which are causing infectious keratitis here. And you would find in most of the cases, there would be a preceding history of trauma here. So that's going to be a very salient feature when you are looking at infectious scleritis. There's always a history of surgery also in cases, in most of these cases. And as Dr. Biswas rightly pointed out earlier, it could be pterygium, small incision cataract surgeries, trabeculectomies, retinal detachment surgeries, and of course you have a much later presentation with surgical induced necrotizing scleritis. You always will have ocular or systemic association. So this is something which you always need to look for here. And the infectious scleritis could be secondary to an ocular infection or could be secondary to a systemic infection here. Ocular, you can find an endophthalmitis, a posterior inflammation of the globe here. It commonly would be associated with infectious peripheral ulcerative keratitis. So these are two common conditions here. The more uncommon ones I will touch upon when I'm briefing you more or elaborating more on the other features. The systemic infections which are commonly associated with scleritis would be tuberculosis, leprosy, trichomonas infections, and syphilis. So these are the common systemic infections, and in the nice case illustration which Dr. Biswas showed, several times there's something which we probably miss in these infections. So it is always good to go and rule out these and investigate for these when you are looking at a patient of scleritis here. And last but not the least, the masquerade presentations of infectious scleritis. This also, sir, had covered elaborately. So you have conjunctival tumors and you have posterior segment tumors, something like melanomas. The common ones are conjunctival intraepithelial neoplasias, the ocular surface squamous neoplasias, you have lymphomas. I've also seen not a tumor but a rhinosporidiasis presenting like a tumor here. And so that's another masquerade with scleritis. And posterior tumors, melanomas are the common ones which would present as similar to a scleritis here. And as sir's lovely ultrasound pictures did show you, there a massation is always seen on a posterior scleritis sometimes, and you could see a B scan showing a high internal reflectivity and a retrobulbar ecoluscent area which presents as an edema in the tenon. So when you look at these, you will be able to differentiate a posterior scleritis, but it's usually easily said than done. There could be these could be more difficult clinical scenarios here. To just look at a broad outlook at what are the various organisms which can cause infectious scleritis. So you have bacteria, fungi, virus, amoeba, parasites. This is again from the Survey of Tile article, which is way back in 2005. And since then, you have several more organisms which have been published and which do cause infectious scleritis. But keep in mind, among bacteria, you have the Haemophilus and Pseudomonas is more common here. You could have Staph and Streptococcus species here. And the more indolent organisms being tuberculosis, mycobacteria, leprosy, and syphilis here. Of course, nocardial scleritis is something which several people tend to miss here, and there are geographical predominances to the occurrence of this infectious condition here. Among fungi, you could get aspergillus. You do see a lot of fusarium here, especially people who are doing a lot of therapeutics here. You would find that the recurrences would be associated with scleritis, and that could be one reason why it's very difficult to manage these cases here. Viruses, Epstein-Barr, Coxsackie, varicella here. So you could have even herpes here, but these are rare presentations, but viruses can also lead to scleritis. Acanthamoeba is one real difficult scenario here, and Acanthamoeba cyst can remain dormant in the sclera and present several years after the corneal infection has healed. And these patients will tend to come back with severe pain and scleritis lesions. I have seen one such patient during my fellowship in the Singapore National Eye Center, a very difficult case to see. To treat ultimately required almost several forms of interventions. So this particular young girl here, who started off with a simple acanthamoeba, small opacity here. So that's one condition where you would find a lot of acanthamoebal nodules in the sclera here. Parasitic infections may not be very common, but you might have to keep them in mind and rule them out when you are not able to find out what particular organism is causing it. Other than toxoplasma, you do have trichomonomal infections as well here. So this is not an exhaustive list, but something which you could always bear in the back of your mind when you are managing these cases. I think this is sort of going to be a repetition of what Sir said here. And most of the scleral lesions can have an overlying episcleral inflammation, which could be nodular or diffuse in the initial stages, and the patient would come on your second or subsequent visits with a frank scleritis here. The anterior scleritis can be nodular, diffuse, and necrotizing with or without inflammation. And when the inflammation is silent without pain, it becomes scleromalacia perforans. Posterior scleritis again can be nodular, can be defined to a particular region, could be diffuse, and you could have necrotizing as well. We'll now move on to a few clinical pictures here so that our understanding becomes more vivid here. So here you have a diffuse infectious scleritis, which is occurring here in around in almost more than 180 degrees of the circumferential part around the cornea. Here, a close-up view of these, and the patient usually presents with significant pain here. Here you have associated severe necrotizing inflammation, and you have the underlying scleral show, the scleral thinning here, and lots of uveal material, and it's also having an adjoining corneal lesion. Several times it could be the corneal lesion which has gone and spread into involve the adjacent sclera here. That's again a close-up look of this particular patient. A nodular scleritis generally tends to look like this. This is more for our residents and our postgraduates here. So it's more of a localized lesion out here. And this is a surgical induced necrotizing scleritis, which was seen several years following a successful pterygium surgery in this particular patient here. Some more clinical pictures here. Here you have a severe non-necrotizing form of diffuse scleritis, anterior scleritis in this particular pictures here. And here you have multiple nodules, multiple punched out lesions here. Remember, these commonly could be characteristic of nocardia here. So nocardia can present as a slow indolent infection. The patient might not be really very symptomatic unless you lift up the lid here, but the blinding complications associated with it is what would alert the clinician and get the patient to meet your doctor. So multiple punched out lesions like this extending throughout the globe, you would find when one is healing, the other one starts showing up. And these are really become very difficult scenarios to manage here. You have more of necrotizing scleritis here. You have a lot of adjoining inflammation, which you're seeing spreading on into the cornea as well in this particular case. Again, here is a peripheral ulcerative keratitis here, or more of a sclerosing keratitis here, or sclerokeratitis. You find the adjoining lesion is largely inflamed, largely informed with several infiltrates involving more than almost close to 180 degrees of the adjoining cornea as well. So a sclerokeratitis presentation is also something where both the cornea and the sclera tend to get involved, but you don't see the characteristic ulcerative lesions as you would see in a PUK. These are cases of healed scleritis. Patients have had multiple episodes and they do tend to be on follow-up with us here. And you would find a large area of the adjoining sclera in the anterior part being very thin with the uveal tissue showing through here. So these are some of the looks of infectious scleritis. A quick recap on what are the salient features. About 18% of cases of scleritis are only considered to be infectious here. So it's something which is considered rare, but you also might find the look would be very similar to what you would find in a non-infectious or an immune scleritis here. So you probably need to rule out all the immune conditions before you would go on to get and label it as an infectious pathology. And several times it's very difficult to isolate an infectious organism. It's not as easy as you would in case of infectious keratitis. And mind you, even in infectious keratitis, isolating organisms need a very detailed diagnostic workup here. The pain varies depending upon the clinical presentation, whether they are simple nodular forms or they're extensive necrotizing forms. The nodules can be either solitary or multifocal. And the presentation in terms of scleritis occurring subsequent to trauma can vary from several days to years following the primary trauma here. The acute bacterial infections have a very rapid course of melt, where you have indolent infections secondary to fungi, nocardia, mycobacteria, which have a slow onset, which have a slow course of the clinical presentation here. Sometimes, as I already said, can be indistinguishable from an immune scleritis here. And the selection of an appropriate treatment hence becomes difficult, as you're not able to pinpoint on the diagnosis of these cases. Always bear in the back of the mind, these are patients who would have come back to you for management of other comorbidities arising as a result of the scleritis. So vision-threatening complications like cataract, glaucoma, and endophthalmitis, loss of vision, and subsequent phthisis can occur in these cases here. So this is a condition which you will really need to be wary of. So more pictures here. You have a very localized case of infectious keratitis in this particular patient. Differentiation between episcleritis and scleritis, I think I won't touch upon. Sir has already elaborated it very detailed manner earlier. So this is a particular picture of a Fusarium Keratitis. I thank Anita V from Aravind Tirunelveli for sharing some of her experiences with me here. So here you could see a corneal button done here, a therapeutic keratoplasty. So it's an opaque button here, and the patient has returned to her about a year later following the therapeutic keratoplasty. And the scraping confirmed this as a Fusarium Scleritis here. So that's how a Fusarium Scleritis presents here. You have another similar case is a recently done therapeutic keratoplasty. You can see the lenticule here. The surrounding sclera has started getting infected and showing a nodule out here. And this is about a week after the therapeutic keratoplasty, earlier presenting with just a simple limbitis and then proceeding on to a frank Fusarium abscess on the adjoining region of the sclera here. So she particularly managed it with a drainage on slit lamp sent for culture, and the patient subsequently, I guess, did not come back to her later on. Another case of a fungal scleritis. This was occurring. This occurred following trauma, following a thorn injury, where you're having a localized irregular nodular elevation seen, particularly in this patient with a history of thorn. Was seen in the OT. The thorn removed here with an incision and drainage and managed with antifungals here, and the patient resolved here. So those are different or varying presentations of fungal keratitis occurring after different clinical scenarios. These are again pictures of scleritis occurring secondary to cytomegalovirus infections here. This was a patient who was CMV positive with a CMV keratitis here and the adjoining scleritis here in this particular patient here. This is a classical picture with most of us cornea surgeons do see. We have peripheral ulcerative keratitis involving a large part circumferentially. Classical features of an infectious peripheral ulcerative keratitis with scleritis of the adjoining sclera of the cornea which has been involved. So that's how you largely do differentiate a PUK because of an infectious lesion and a Murren's ulcer in clinical scenarios. Yeah. This was one particular case which was co-managed by me and my junior colleague, Dr. Lomi, in RP Center here. And this was a young girl who presented with multiple lesions. I think I presented this in one of the Kerala conferences recently, as well as one of the challenging or interesting cases here. And this patient was a case of suspected case of Behçet syndrome, had classical features of conjunctivitis, oral lesions, urethritis, skin lesions here. She was subsequently investigated for the Behçet's disease here, and this is how she presented with a circumferential peripheral ulcerative melt along with a circumferential nodular, circumferential diffuse anterior scleritis with significant scleral melts and uveal prolapse and show, and required multiple surgical interventions in terms of extensive patch grafts interventions to save that particular eye. This was a bilateral presentation in this particular patient. Yet another case, this is an immune scleritis where you are seeing a sort of a less invasive or a less active lesion. It's more quieter compared, and if you look at it, it sometimes becomes very difficult to differentiate this from an infectious lesion. But also remember, your immune scleritis can have secondary infections, and that's something which you need to rule out. So quick look, or let's quickly run through the several pointers in infectious scleritis. So up to 10 or 18% of cases of scleritis tend to be infectious. They can have a poor prognosis, especially in aggressive infections. And because of the avascular nature of the sclera, which also does not enable good drug penetration in management. A variety of organisms from bacteria, virus, fungi, protozoa will be involved in these infectious lesions, and the infections can be either endogenous or exogenous here. Trauma, immunosuppression, conjunctival pterygium surgeries are common. Region-specific systemic infections, something which the treating physician needs to keep in mind, like tuberculosis, syphilis, toxoplasma, or leprosy here. The presentation can be varied depending upon the severity of the lesion or the morbidity of the condition which is being associated, which is presenting here. Bacterial scleritis can have delayed occurrence even after surgery or trauma, and can still be a dormant organism and not necessarily have to present in a virulent aggressive progression here. When you look at diagnostics, you would probably look at using the help of ultrabiomicroscopic imaging here, UPM imaging, anterior segment OCTs, and several papers is something. When I did look at literature, it was interesting to find that people do look at CT orbits to also to take the help of CT orbits for as a diagnostic modality in managing and in looking at the progress of the conditions here. Goes without saying, you would want to do scleral scapings here to isolate the organisms here. And now with the extended diagnostics, molecular diagnostics to our help, you have PCRs of the tissue specimens, either from your scrapings or for your biopsies, and immunofluorescence, which can really help you and in the diagnosis of your infectious organism here. But it is always imperative that you rule out an immune pathology before you would initiate a treatment for a case of infectious keratitis. Should remember in the mind that starting high doses of immunosuppressants and steroids could be detrimental in a case of infectious scleritis. So this makes it that much more difficult for your treating physician, especially if the clinical conditions cannot be really clear cut in when they are presenting to you. And remember, you would probably need to give intravenous systemic systemic antibiotics, intravenous antibiotics, along with surgical excisions cryotherapy in the management of recalcitrant cases here. Nocardia scleritis, as I showed you here, can have multiple nodules here, can have poor responses to fluoroquinolones. This is one condition where nocardia probably does not tend to nicely respond to your medical management here. Mycotic scleritis again can have progression, poor prognosis, and these are patients who have associated cataracts, serous detachments, choroidal detachments here, and ophthalmitis, and late diagnosis, poor penetration of your medical management, all result in poor prognosis of these cases here. Mycobacterium is something which you probably will have to rule out. It is not always mandatory that you have systemic lesions here, but I do find this in our part that several of the cases that patients are put on anti-tuberculosis treatment on a suspicion of mycobacterium, which is something I think several of us do not agree upon here. Toxoplasma and treponemal infections also need to be considered here. A quick look at certain diagnostics here. So this is one particular paper which I was able to locate, and they've used the CT orbit for following up and have recommended this as one of the other modalities. But I think we do have the ASOCT and UBM to good effect that we really do not need to move on to a CT unless and until you feel it's really required. Just sharing a couple of my experiences with my colleagues at our center, where we had looked at masquerades of infectious scleritis. These were actually tumors which presented as scleritis here, and you could see a couple of these cases here, large diffuse scleral nodules here. This, of course, is more classical of ocular surface malignancy here. A UBM in these cases really helps to pick up and helps to show the extensive involvement of these OSSN cases here. So that's something which you would always need to remember when you are managing cases of infectious scleritis. This was again another particular interesting case here. Came with a nodule which had healed and a melt, and I had done a patch graft for this particular because he had presented with an extensive necrosis here. And on subsequent follow-up, I found that the patient had another nodule which was developed a little away from from the earlier lesion here. And the fundus picture showed an extensive serous detachment as well with posterior extension. We did subsequently had to go and manage this patient and enucleate the eye. This was an invasive OSSN here, confirmed on histopathology here. And this is a UBM picture of the particular patient here. Those are masquerade syndromes. And in infectious scleritis, the complications of scleral thinning, corneal thinnings, perforations, uveal prolapse, secondary glaucomas, hypotony, uveitis, occurrence of cataract, posterior segment problems, anterior segment ischemia, subsequent phthisis. The chances of these occurring could be quite high, and the physician needs to be prepared for managing here. I'm not going to delve into the depths of diagnostics in terms of ocular microbiology. It's pretty much similar to what you would do for any other infections like keratitis or endophthalmitis, your gram stainings, your KOH stains. So I'm just quickly going to flip over to these sites because of a lack of time. But remember, culture sensitivity, diagnostic scleral scrapings of the smears, culture inoculations. And today, I think we also have a good alma mater on antibiotic sensitivity testing to see if these cases are responding to the management which you're giving here. So that would be another extensive help even you would take with your ocular microbiology colleague here, and to see if these difficult scenarios are responding to the antibiotics or the antimicrobials which you are giving. In cases where difficult diagnosis, one-eyed patients, you probably would like to look at molecular diagnostics like a PCR to isolate the organism here. And this was a case which I just did recently, about 2 weeks ago. The patient, I'm sorry for these pictures because we couldn't take good clinical pictures. These are taken out of my surgical video here. So just done about 2 weeks ago, the patient presented, was a case of scleritis seen earlier and resolved, though we didn't have a particular diagnosis on what the organism was. We still thought she was she was an immune keratitis, and she came back about 6 months later here. And this time, a particular inflammation and melt in infranasal part of her part of the globe, with extensive melt and necrosis and uveal prolapse here. So I had to do a large. I tend to use corneal tissue itself as a tectonic patch for this sclerocorneal melt here. And she's currently recovering, and we isolated coagulase negative Staphylococcus aureus in this particular patient. These are similar pictures as you would get in infectious peripheral ulcerative keratitis patients with very severe mebomitis here, blepharokeratoconjunctivitis. We have staphylococcal immune abscesses also, which can lead to such presentations here. I had one other patient of rhinosporidiosis, which presented with extensive conjunctival lesions, scleral melts, for which I'm sorry I could not locate the photographs of that particular patient here, and had to do extensive scleral grafts for this patient. He came back later with about 2 or 3 years later for a cataract surgery, and still enjoys a vision of 618 after this extensive, though there is a little staphylomatous protrusion in the sclera because of his extensive inflammation. So what you need to think about in management is the broad spectrum coverage, the availability of the antibiotics, the cost, the region specific epidemiology, and apart from the use of steroids, anti-glaucoma treatments, cycloplegic lubricants, and you're taking them for long-term management. Closing with just one particular slide on what you would need on the management for the various infections. This is pretty much similar, as I said earlier, to the management of infectious keratitis for your gram-positive cocci, negative rods cocci for your mycobacteria. So this is something which is there available in the textbooks, and this is pretty much similar to the line of management of infectious keratitis. For resistant organisms, you do have much more. You have vancomycin, you have the use of for Pseudomonas, you have linezolid, colistin, imipenem, and remember, you would probably need to give them intravenous in cases of scleritis patients here. This is again a slide of just how you could make all these formulations. I think I will stop here, and we'll hear more about management from Somshila. Thank you again, and I wish to acknowledge all of my friends, Sujata, Revati, Anita from Aravind, LVPI, Bhuvneshwar, Sujata, and Lomi, who shared some of their pictures to make this a very interesting talk. Thank you again for the opportunity to be with all of you on this Independence Day.
Thank you, ma'am. Thank you, ma'am, for the exhaustive talk and such great clinical photos. I think it was very, very interesting. There are a few questions Dr. Somshila is answering on the chat box. I'll just read it out. One main question is, how do you differentiate between infectious and non-infectious? What are the pointers to say that it's an infectious scleritis?
Then you commonly see non-infectious cases, because we generally, when the approach to a management of a scleritis is that you tend, by and large, look at it as an immune keratitis or an idiopathic keratitis. What you generally pointers towards infection are it is usually very aggressive. You have necrosis, you have purulent discharge in these patients here, and several times, as Dr. Biswas also rightly pointed out, you would probably want to rule out immune conditions which could be associated. So a good history taking from these patients, looking at systemic pointers for a systemic infection here. So that's how you would really would want to differentiate. Frank infections, usually it's not a difficulty here. And you would be able to, if you do a simple corneal scleral scraping here, you would be able to isolate these cases here.
Thank you, ma'am. Dr. Prithviraj is asking, how common is scleritis associated with ocular tuberculosis?
I think when you look at cases of systemic tuberculosis, you have patients who have frank history of and anti-tuberculous treatment. I've had patients who have had earlier history of anti-tuberculous, have completed their anti-tuberculous treatments here, and then presented with ocular lesions. And of course, unless you do a biopsy in these patients, and several times a biopsy again is not conclusive on these patients. There are patients who are suspected tuberculosis, and these patients have been sent for their quantiferon tests, and the quantiferon tests have turned out positive, but there is a large amount of false positive and false negatives in these particular cases. It's really difficult to say what exact percentage is going to be associated of systemic tuberculosis, which is going to be associated, and whether you need to start these patients on anti-tuberculous therapy just on per se of looking at an ocular lesion when you are not sure of the diagnosis is something which is you would always want to debate upon. I think Dr. Biswas and Dr. Somshila can add on more on this.
I think is that tubercular scleritis is often a diagnostic challenge. I don't seeing it scleritis. I cannot make out that it's a tubercular or
I
non-infectious.
totally agree, sir. Yes.
Students, systemic investigation reports which may give us a clue.
I don't think that would really make it a good clue, because there may be a systemic infection and I can be having a different disease. Until unless you take tissue diagnosis,
Yes,
it
so
will
I
be
think it's a
difficult.
tissue diagnostic which is going to clinch, and there are a lot of false positivities. I think you will totally agree that several your quantiferon test is not always 100% conclusive of tuberculosis, and in India you would find most of us, you do a manto, you would find our mantos to be a little more about what is borderline and what is desirable here. So by and large, it is in collaboration with your system, with your physician, in collaboration with your ocular diagnostics, which is probably going to let you know whether you're going to start on antibacterial, on anti-tuberculous therapy for these patients. So, Sheila, your views on these?
Yeah, I would take up this question, the answer in two ways. The first is that, as Dr. JB has so correctly pointed out, that there are two ways in which tuberculosis can be involved in scleritis. One is the active or more of an infect, when you have the actual tubercular bacteria, when you can isolate that from any of the ocular tissues, either by actually, if you have a abscess and you can isolate that, Dr.
Yes.
JB has got it from the enucleated globe, or if you do PCR of any of the ocular samples, and then that also comes positive. So that is a live bacterial infection of the eye. And that is very rare. Maybe in 2% of all the cases of infection, you might get that. The second and more, we presume, commoner way of having tubercular related scleritis would be the immune-mediated route or the hypersensitivity route. So this is when you have a patient who has maybe nodular scleritis and you rule out everything. The patient is not really improving to just immunosuppressants alone. And then there is high elevated mantos, and there is maybe a positive. If you want to take quantiferon TB gold, we don't consider that. If the mantos is highly elevated, then quantiferon TB gold is not really required. Or if you do an HRCT and there is something over there, so in that case, you can consider that this is a hypersensitivity response to tuberculosis, and you would start the patient on ATT and hope for a response. So these are the only two ways, I think, in which you can. So sometimes it turns out to be like a hindsight diagnosis. You think about it later on when everything else is not working in some cases. Or sometimes you systematically investigate the patient and you detect that. You're just by chance alone, you detect that on HRCT chest or something like that. And then you start the patient on treatment.
Thank you.
Dr. JB, what would you say? Anything else to add?
No, it would be my, after ruling out other things, then only I
Right.
consider TB.
Right.
That one, if I don't depend on the TB test coming positive only,
Absolutely.
and then taking it as a TB.
Yeah.
Thank you, sir. Dr. Mihir is asking, how common is fungal scleritis in your practice? Vanati, ma'am.
Okay, yeah. See, when you have frank history of trauma with vegetable matter here, that is something where you would definitely be able to find out that's a fungal scleritis, a post-traumatic fungal scleritis. When you're doing therapeutic keratoplasties, when you're looking at that grave fungal infections which have spread up to the sclera, then you know these are patients where you have an associated fungal scleritis. Several times this tends to get missed at the time of diagnosis by the residents here, largely because these are chronic cases, especially at our center. We do not jump in to do therapeutics very early. So you do have a lot of conjunctival injections, which you see secondary to the aggressive antifungal therapy itself here. So this would mask, or this would lead to missing of an associated scleritis nodule here. So this is more common in cases where your infection is long drawn, it's chronic, and you would find the patient coming to you with significant pain. So I always advise them to shift and look around, not just at the cornea here. It's very difficult to say how common. It's not really very common, as because what you put in as infectious scleritis is about close to 20% of your cases of what you see the infections is where you have scleritis is being associated. But when it's associated, then it becomes very difficult to treat them. And you will look for them specifically if you're finding recurrences after a well-done, a well-contained therapeutic keratoplasty here. And sometimes remember, these organisms can remain indolent and they can show up even after a year, after several months and a year after your primary successful surgery.
Thank you, ma'am. Ma'am, when do you decide that you have to go for a scleral scraping? A patient with scleritis not responding to.
Yeah, so when you're having an active ulcerative lesion, necrotizing lesion, you can find a raw edge here. Then you could scrape out these patients here on the first presentation. And if you find that they are not responding to your medical therapy, if you are starting on an empirical therapy, and you have an abscess pointing here, then you can do an incision and drainage either under the slit lamp itself, or you can do an excision biopsy kind of, if it's a large nodule which has been standing there for quite some time, it's increasing them. You can do it in your theater to take out tissue specimen here and send it for your diagnostics here.
Thank you, ma'am. Thank you, ma'am, for the excellent presentation. With the next talk.
Can I ask one question to Dr. Vanati?
Yes, Sujit.
Yeah, ma'am. Regarding this nodular scleritis, in cases of nodular scleritis, when you are suspecting some infectious etiology, when you go for a scleral biopsy, can you just tell us a few points, like how you can do a scleral biopsy? It's quite different from we cannot do a scleral biopsy so easily.
Yeah, I really agree to you on this particular. Doing a scleral biopsy is something which I also am not very fond of doing here. But when you have an active pointing abscess here, you have an abscess which is you're able to clearly demarcate. You probably like to back it up with a diagnostics on your ASOCT or on your UBM earlier to look at the or delineate the extents of the infections here. And if you feel the abscess is amenable to an incision and drainage, a simple needle incision and drainage should suffice here. But if you find that's not possible, then you take it on to an OT, and you could do a simple excision biopsy with a particular, avoid the necrotic areas, and go in for a deep tissue specimen, something about 4x4, in both in your extent of X and Y axis and in the depth of the lesion as well here. And that's something where you can take out a tissue sample. If you have a delineated nodular lesions here, I think there are incidences when you could excise to an excision biopsy of your nodule as well here. So this is not something which I do very commonly most of the time. So it's either a scleral scraping for a smear, or an incision and drainage, or a nodule biopsy, which could be an excision biopsy in toto once you're able to delineate the extents of the infection. And you're also sure that you're not worsening if you're not planning a subsequent patch along with it. I usually don't plan a patch unless you have your diagnostics in hand, because that's not going to result in good success of your patch if you're not backing it up with good antimicrobial therapy.
The main worries will be about the thinning the cornea, which is, the scleral area or the nodule.
If you have a large nodule, which is probably not decreasing, it's increasing there, and that is where you could safely go in and do an excision biopsy here. But if there's extensive thinning, then you would contain your thinning with your, then you would contain your inflammation, look at your microbiology backup here, and then take in for a surgical management with a tectonic patch.
My question is relevant in actually I have a patient in which I believe it is not infectious, because there's no pointing. Actually there is a two nodules which for more than 6 months and which is refractory to almost all the treatment. And he has been extensively worked up for a TB also, but like what we have all discussed, like Manto, chest X-ray, CT, everything is negative, and even the ESR is also very, it's 9 or 10 or something. So there is absolutely no clue for tuberculosis as of now.
Okay.
So, and he's not having any systemic autoimmune disorders also. All the workup is so far negative. So the next, I've been suggested, like, can we go for a scleral biopsy? So I really worry if I touch that sclera, which is inflamed nodule, am I going to create more problems for that patient or what?
No, not much.
So I can go for a scleral biopsy.
Yes, you
Yeah.
can. Yes, you can. Yes.
I think that is the only thing which is
Because
going.
that's the only diagnostic which you right now have, because you come to a dead end where you probably do not know which way to go in terms of management. You've exhausted everything. And if you're not sure if it is an immune one, then starting steroids could worsen if it's an infectious etiology. And you see that you have cases where they have syphilis positive patients which would present as nodules. You can have leprosy patients, though these are very rare. You can have trichomonomal infections here, which can also present as nodules here. So these are some things which you still can't rule out on investigations, and you probably will need a biopsy.
This patient, because he has already completed one round of
Medication.
steroids, methotrexate,
Mhm.
mycophenolate, and he
Okay.
has completed all courses, and now he has come to a stage where the rheumatologist is planning some biological agents like adalimumab, and before that he would like to have a little biopsy.
Okay. So
Dr.
you still
Sujit,
look.
is the patient symptomatic still?
He is having a dull ache, a dull pain, and the eye looks slightly. It's it looks slightly in ophthalmos, slightly topic
And
eye.
and you mentioned that there are two nodules. Is that right?
Yeah,
Yes,
that's what he said.
look at it. I don't have the picture. I actually wanted to show the picture just for a diagnostic picture, not for the full case, but I couldn't retrieve it. It's just two nodules, left eye infratemporal, and it is there for more than 6 months. And as I told, and he has already completed all these treatments, like all the workup also. Nothing so far positive.
What is
Extensive
his
workup
immune
by
diagnosis? What is the diagnosis which a rheumatologist has placed for him?
No, the rheumatologist has worked up completely, extensively. All the possible test has been done, and nothing has
Nothing
come positive.
has come out positive.
Yes,
Okay.
just after ruling out tuberculosis by routine methods like Manto and all those things, he started on methotrexate, which didn't show any. He started on steroids, but his blood sugars got elevated, so and then reduced the dose of the steroids and started on methotrexate, but still no difference. And then switched on to mycophenolate, no difference. Now I think he is planning for biological agents actually. So I still believe, sir, in such cases, the tissue diagnosis could give some clue for tuberculosis, right? We may
Yeah.
not be taking up from the routine test actually.
But if the
Because
patient is not very symptomatic, I will not go for biopsy.
he is symptomatic, sir. He is.
So then you can go ahead for the biopsy before putting him on biologics.
I didn't get you, sir.
If you want to put him on biologics, that would be if it's a tuberculosis infection or any infectious process, that would be really very harmful for the patient, because if he's harboring some foci of tuberculosis.
So you feel it is better to do the biopsy first and then
Yes,
go.
biologic. If we have exhausted all the other investigations, it would be going for a biopsy. So biopsy would show the collection of lymphocytes, and that if you see the granuloma, it would go in favor of tuberculosis.
Dr. Sujit, one thing I've learned the hard way is that if a patient of scleritis who you think is immune-mediated scleritis does not improve with oral steroids, then that patient is not going to improve with oral immunomodulators. So if you give a full dose of oral steroids for 3-4 weeks and there's no change, it means that we're on the wrong track. So the differential diagnosis for these would be, we could be looking at viral inflammation, or we could be looking at other infections like Mycobacterium, as was discussed, or it could be a masquerade, like Vanati had pointed out,
Yes,
or
yes.
or a benign kind of a nodular lesion also. So 3 to 4 weeks is almost, I think everybody would agree, Dr. JB, that if you start the patient on adequate steroids and if there's nothing, no change, then it means that we're on the wrong track.
Yeah,
I
try with immunosuppressive agents also.
Yeah.
I'll go one more step.
Right.
Yeah.
But it depends. Maybe you had some initial response.
Yeah, I think I would agree with Dr. Somshila on that, almost most of the immune scleritis, you would find a good response, because you do tend to bombard them systemically with extensive steroid therapy in these cases here. When you do not find a response, you probably are looking at other causes of scleritis, and it's probably not an immune case here. And as she rightly pointed out, you have a significant amount of viral cases which could cause scleritis as well. And identification is going to be really difficult in if it's going to be a viral scleritis here. And mycobacteria, again, it's not that if you do a tissue biopsy, you're going to get it out on a tissue biopsy in these cases. You probably will be able to find some amount of inflammation. You might land up with finding an inconclusive evidence even after doing a biopsy in these cases. The chances of that is going to be quite high, especially after you've given such an extensive course of immune modulating agents for the patient. So it's really not going to be diagnostic. You probably will not be able to find a mycobacterial organism which you'll be able to culture or take out on a PCR after you've treated for such a long period of time. So these are some factors which you'll probably keep at the back of your mind, and you still might land up being inconclusive. And I would probably look at alternative therapies, like if you're looking at a viral, you could look at nocardial infections here, it could be treponemal infections. And mind you, several of these would probably occur without a systemic pointer in these cases. So you probably would like to change your course of medications when you look at these patients. But I agree it's a very difficult case on your hands.
I feel that if you're on the pathologist's point of view, I would be able to lean towards the diagnosis of tuberculosis looking at the histopathology. If we see that epithelioid cells, histiocytes over there, I will, or formation of giant cells, or a caseation necrosis, I would be able to go towards the tuberculosis, and then I will do a PCR for Mycobacterium tuberculosis DNA, and then clinch the diagnosis.
Yes.
Okay,
think-
moving on. Shall we go
can
to the
move
next
on.
talk?
Yeah, we'll move on to this next talk.
Now that we have seen the varied clinical presentations of both non-infectious and infectious scleritis, it is very important that we follow certain rules and guidelines in our day-to-day OPD practice so that we do not miss out any causative factor inadvertently. And to help us with that, we have with us today Dr. Somshila Murthy. Dr. Somshila completed her fellowship in Cornea from LV Prasad Eye Institute. She has also obtained fellowship in uveitis and ocular pathology from Doheny Eye Institute. She has to her credit over 100 publications in peer-reviewed international journals and has served as the principal investigator in over 20 clinical trials. As an acknowledgement of her achievements, she was awarded the Achievement Award by the American Academy of Ophthalmology. She has been working as a full-time faculty at LV Prasad Eye Institute for the past 19 years, and she also heads the Cornea Fellowship Program at LV Prasad Eye Institute. I invite Dr. Somshila Murthy to give her presentation on practical guidelines to be followed in the management of scleritis.
Thank you very much, Dr. Mihir. At the onset, I would like to thank KOS and Dr. Sujit, as well as Dr. Dalia and Dr. Vijayalakshmi for having me as one of the speakers. I'm in very august company. And today we are talking about trying to tame the fire, which is scleritis. So these, Dr. JB, coincidentally, when I put this slide, so these are who I consider my teachers. They may not directly taught me, some have, but some are my teachers and my well-wishers, mentors. So everybody probably knows or should know Professor Narsingh Rao, who's pretty much the mentor for many of us. And of course, Dr. Biswas, I've learned so much either directly or indirectly from his publications. Dr. Sagwan is my mentor and friend and guide who was with us at LV Prasad. Now he's moved to Delhi. Dr. Amod Gupta, again, passive learning by all his teachings, and Dr. Ratinam, who's a very good friend of mine, as well as just an amazing, passionate lady of uveitis. So I just wanted to acknowledge all my teachers today because it's a special day, being Day of Indian Independence, and I'm happy that I'm part of this meeting. So coming to the way I am, I'm a surgeon. I have a very practical approach. I cut and send off. And I also train under pathology. So I cut and send it off to me. I try to look at it, the pathology as well. So it's a two-edged thing, but I'm just going to help you or lead you how to manage these cases. What is a practical way of managing these cases? We had two wonderful presentations. Half my work is very easy now because Dr. JB talked about immune-mediated scleritis in great detail, and Dr. Vanati talked about infectious scleritis. So you got a pretty good overview of what kind of diseases you're supposed to look at. Now, how do you approach these cases? So in order for each and every one of you to approach these cases, I think the first question you should ask yourself is that in your practice, whether it's institute-based or your own clinic-based or multi-specialty, how frequently do you see these patients in your clinic? Because scleritis itself is pretty rare in the population. And if you're in a general ophthalmology practice, you may not see them really very frequently. Supposing you are able to answer question one, then the second is that how confident would you be in managing this disease? Do you have access to good lab facility for systemic investigations? This is very important because you have to have a reliable lab, even PPD, all the simplest of investigation you think, they should be done reliably. So do you have access to good microbiology and histopathology facility? And microbiology is very important because of the infectious scleritis load that you're going to see. And then lastly, but not the least, so it's really wonderful that we have a rheumatology colleague here for this meeting. And do you have availability or accessibility to these colleagues who will understand you? You pick up the phone and tell them that I have a patient who has scleritis. Can you just see what's their systemic? I mean, isn't that very vague for the rheumatologist? But they're very understanding and they really help us out in managing these patients. So if you have your entire set ready, so it's like having the entire instrument set for a surgery, you have to have everything ready before you go in and operate. So if you have this entire set ready, then you may be ready for managing these patients, and that's the purpose of my talk. So the first question is that how frequently do you see scleritis in your clinic? Maybe it's very rare because, as I told you, that in the general population itself is very rare, but it's still, you should at least, all of you, we know that how to diagnose this, but it's not just diagnosing it. We should be able to figure out which one is immune-mediated versus infectious, which is anterior diffuse kind of scleritis versus a posterior scleritis, or is it a necrotizing scleritis, because as Dr. JB said, that has more systemic implications versus a non-necrotizing scleritis. So it may be rare, but you should be able to diagnose these various entities. The second point that I had is that if you're not really going to manage the cases, at least you should know in which cases, what is the initial management. So if it's an infectious scleritis, you recognize that. Do you know the appropriate antimicrobial that you would like to start? If it's maybe a diffuse anterior scleritis, you can at least start the patient on topical NSAIDs or topical steroids, oral NSAIDs, and then refer the patient across. So you can refer it to either to an institute or to a colleague of yours who deals with such cases. Because of the rarity of the disease, it's best to either get trained very well or to send them to a colleague who's used to managing these cases, because they would have seen many more and they would figure out maybe better than us. For example, I never touch patients with glaucoma or any other specialty except mine because I've lost touch with those cases. So if, on the other hand, you either often or frequently see these patients, or you have, like me, like a passion to know about these cases and how to manage them, or you may be working in a remote place and the patient cannot travel. So you are the doctor for them. You're the only specialist for them. So in these instances, you really need to know about these particular cases and you need to know how to tame this fire. So because I saw in the chat box about episcleral inflammation, I just put up this slide. So episcleritis, as Dr. JB or the previous speakers mentioned, is the more benign cousin of scleritis. And you know that there is just an irritation. There isn't any real pain. When you add an elephant into the eye, and the entire red area that you can see here on the slide on your right is going to disappear like this. So in our mind, it's not at all a sight-threatening disease or a destructive disease that the patient may have, but for the patient, it's very bothersome. And some of these cases can have systemic vasculitic or connective tissue diseases in association. Some of them can have local conditions around the eye itself. And as I mentioned, it's not associated with visual loss. So would you investigate them? Probably most of the time, because whatever experience we have, that majority of these investigations turn out to be negative. So I would say in the first few episodes, I kind of don't investigate them. I may perform investigations similar to scleritis cases if the patient has a cycle of continuous episodes of episcleritis or has something else that is systemically pointing towards a disease entity that is associated with scleritis. And then somebody asked about management. So how do you manage them? Typically, just about any of these drugs you can choose. You can choose a topical non-steroidal anti-inflammatory drug. You can choose a low potent steroid, or you can choose a potent steroid even if the congestion is more severe. And just like what they say about many things in life, that you repeat as required. So the patient finishes up with the treatment, may come back later on. So you give the minimum amount of treatment that gets rid of the condition for you. And only in those multiple recurrent cases where may or may not have something systemic, there you might resort to an oral immunomodulator. So far for Episcleritis, I've not used even for a single case ever. Most of the time, they get settled down with this and it might disappear. So that was about Episcleritis, just a little bit. Coming back to the meat of the topic is how to proceed in a case of scleritis. So the 4 or 5 things I would look at is the anatomical diagnosis, the age and gender of the patient, how severe is the disease, and is there a systemic component? Are you suspecting it, or is there already a systemic component? Yes or no? So this is the classic, this is a very, very robust classification, still relevant, although it was published in 1976 for immune-mediated scleritis. We divided it as anterior and posterior. And as Dr. JB already mentioned that, so I need not go through it. But just to say that the most common variety that you might see as a general ophthalmologist would be, or even in the clinic for that matter, would be an anterior scleritis. More often, you would probably see a non-necrotizing type and a diffuse variant. And this is kind of the best case scenario that you would like to have. So that's about anatomical diagnosis being diffuse anterior, more common, followed by nodular, necrotizing, and posterior scleritis. As Dr. JB highlighted, posterior scleritis is very, very underdiagnosed. So how to proceed? If it's the diffuse anterior, these cases are the best in terms of responding to treatment. And you can be a little bit less on aggression in treating them. And you have a choice of varying your selection, whether you want to add immunomodulators or not, or maybe you can just treat this first episode and see what happens after you've investigated the patient. In nodular, you can expect that it will be slightly more resistant to initial therapy. You can expect recurrences. So your antenna for starting immunomodulators would be on the higher side. Necrotizing, you know that there's a highest chance of systemic component association. And here you will be aggressive in starting therapy, maybe even collaborate with the rheumatologist. In posterior scleritis, the systemic component, maybe it's lesser based on published studies, but you do need aggressive treatment, perhaps because it may be diagnosed a little bit later. All right, coming to the age and gender. So why is this important is that when it's gender, certain diseases have a predilection, as Dr. JB mentioned that he's never seen a case of SLE but with scleritis, but they've reported it, so it probably does exist. And obviously that would be in a female patient, not in a male patient. So the investigations also, you would expect patients with rheumatoid arthritis, slightly more female preponderance, obviously. The ANCA positivity for GPA would be slightly more male preponderance, and ANA positivity would be more in female. So that's the importance of gender. In terms of age, you might have 2 spectrums, so to speak, of age in scleritis. One is that the youngish to middle-aged patient, and the second is that the older patient, the elderly patient. So the investigations and management would be a little different in both these cases. For example, if an 80-year-old presents with scleritis and everything else is absolutely fine for the patient, so by the time if the patient had a systemic disease, it would have manifested by now. So I would be less likely to investigate. I would investigate, but I would know that the pretest probability of finding something systemic is probably on the lower side. In fact, I would be a little bit worried that the patient should not have something like a masquerade. And also, not only the etiology, but also my management. Again, in the elderly, I would be less gung-ho about using something like cyclophosphamide or long-term oral steroids for these patients. Whereas in the younger patient, I would be a little bit more aggressive in treating them, especially if it's necrotizing. So that was about age. And you might just have the pediatric patient. Pediatric scleritis is very rare, but it's not unknown. And you can have a few cases presenting within the pediatric age group. And here you want to avoid oral steroids, or at least prolonged use of oral steroids at all costs, not to interfere with the growth cycle. And here sometimes you might want to resort to immunomodulators much earlier on, or even to biologicals to do away with the need for oral steroids. And investigations also would be slightly different for these patients. So when I'm talking about investigations, let's talk about when. Investigations in episcleritis, at least my personal preference and whatever I read of literature, is that you may not investigate. Maybe only if it's persistent or recurrent, you can investigate. Having said that, I can't recall if I detected a new case of a systemic disease with episcleritis. I know that I've had patients with the disease like rheumatoid arthritis or Crohn's disease come in with episcleritis, but I have not detected a new disease in a patient. So I don't know if I'm a little reluctant to do any investigations for them. Then what about scleritis? As Dr. JV mentioned, all scleritis, not just the bilateral scleritis. Also very, very important for necrotizing scleritis. If it's unilateral necrotizing, think a little bit about infection also. Keep that in the back of your mind, because it could look like a necrotizing scleritis, but it could actually be necrosis due to infection. So which investigations? So a very simple screening tool. Now this depends on if you're the only doctor for the patient and that sort of story, or the patient and you can't send the patient anywhere else. Or it also depends on, whether you want to do certain investigations for like a baseline, which anyway will be done. So you're not wasting the patient's money, and it helps you understand and treat the patient better. So we typically do just like a screening evaluation with some of these investigations, and the most important ones which I've highlighted: the rheumatoid arthritis factor, the ANCAs, and ANA also we tend to do. So here's a result of a patient with ANA positivity, which then you have an extended ANA profile. So this I was actually putting up to ask the rheumatologist later on. So what is the significance of ANA? Because I've heard many rheumatologists say that it doesn't matter. It's only a test for more towards SLE. Whereas we see a lot of ANA positivity and ANA vasculitis kind of positivity, not just in scleritis, but many of our dry eye patients, and even in mucous membrane pemphigoid. So really we need to know what is the importance of ANA. And Vanati mentioned about syphilis. So, and we are more and more sensitive now. So in our initial screening panel, we also included TPHA test, because you can pick up that rare case of syphilis, which is so treatable. So, and you don't want to use steroids for them. And most of our patients, because we know eventually we're going to put them on oral steroids and immunomodulators, we always start off with the baseline PPD, X-ray chest, and those kind of investigations. Not that we're suspecting tuberculosis in them, but just for a management of these patients. So coming to the what? So what needs to be investigated? So all scleritis, as I mentioned, diffuse anterior unilateral scleritis, as I mentioned, and necrotizing scleritis, where you're more likely to get these investigations positive. So don't be disappointed or don't be surprised if the other scleritis, which is a good 60-70% of scleritis, would be negative for ANCA, ANA, or RA. So that's what you're likely to have in the community. Whereas you will again not be surprised when you see that the necrotizing scleritis person may have seropositivity for these investigations. So that is what you expect for these patients. So if you're doing the investigation, then it's typically our headache to figure out how do you interpret raised ESR and elevated CRP. A lot of ophthalmologists give a lot of importance to this, but don't treat the lab test. So if just because the CRP is elevated, that doesn't mean that you have to increase your immunosuppression for these patients. It may mean that it's still elevated, but you have to go based on the clinical response of the patient. Then you can have ANCA levels which may initially be positive and later negative, so that's a good thing. But also remember that even if you have negative ANCA, but the clinical picture is necrotizing scleritis with PUK or something like that, that is so classical for GPA in other instances. So you can still have what we call, the rheumatologists may not agree, but we can still have an ocular form of GPA where the ANCA can be negative. And along with RA, also you can do an anti-cyclic citrulated peptide antibody as well. All right, and these are the add-on investigations which the rheumatologist would definitely get done for us. In certain cases, you can have HLA-B27 positive scleritis, and the B5, 51, 51, and 52 also can be done. In case of viral suspicion, you need to do other investigations, not serology. You might want to take a specimen for PCR from somewhere from the lesion. And in case of positive mantos, you might want to push the patient towards getting, if possible, an HRCT done to see what's happening. So in other words, if you want to classify the investigations, the first bunch of investigations here are for managing the patient. So these are not really for diagnosis. It's not like I'm suspecting that the patient has tuberculosis or something. but it's because I'm going to manage the patients. The patients may go on to long-term immunomodulators and or maybe even biologicals, and depending on the disease and how it responds. So this is for managing the patient. The second set of investigations are, which I've listed most of them, are what you might help you in labeling the disease. So an etiological classification like RA positive, patient may not have rheumatoid arthritis, but you might label it as RA positive scleritis, or you might label it as ANCA positive scleritis, or it may be GPA if the patient has some systemic component. If not, you label it as ANCA positive scleritis. So this is helping us to understand that this could be the possible etiology for these patients. And the last part, the second part is for us as ophthalmologists is very important, is the local investigations. Dr. JB and Vanati, both of them talked about the anterior segment OCT, and I also use it just like them. Earlier having used UBM, now many of us have shifted to OCT. UBM still has its utility, especially in infections where you can see the infection, how far backward is it going? And of course, B-scan for posterior scleritis. And based on whether you're suspecting infection, as we already discussed, we need microbiological workup. In Masquerades, we might want to get an impression cytology first. And we've just talked about scleral biopsy for these cases, that especially that rather very confusing case and a tough case that Dr. Sujit has shared with us. And we have learned for the past few years now is that herpes group of viruses can much more frequently cause scleritis than we thought possible. And in a patient who does not respond to, which looks like scleritis, immune-mediated, but does not respond, responds initially, but beyond a point does not respond to oral therapy of steroids, then think of viral, and we simply start a therapeutic trial of antivirals and we see the response, and sometimes you get success over there. And this is exactly one such case. So this patient is a 44-year-old male with two months history of pain and redness. So one very important piece of history which my fellow missed was that there was a lesion on the forehead. The patient himself did not remember that 2 months back that there was something that was going on. And so this is the anterior segment OCT. It doesn't, looking at it, it doesn't tell you that this is infectious, viral, or it doesn't give you etiology. But what it does tell you is that this is the conjunctival area. There are some dilated vessels here, and most of it shows that there's a lot of thickening. So it's much more than the clinical picture. So because of the pigmented lesion on the forehead, we label this condition as zoster-related scleritis. And in this picture, you can also see these peripheral faint corneal lesions. So these are lesions because later on they disappeared when we started the patient on therapy. So there are faint corneal lesions here. And this was after starting the patient on oral acyclovir 800 milligrams 5 times a day. So this is what I'm trying to show in the arrows. And this was a few weeks later. Already you can see that there is some change in the OCT. And these dilated vessels have become more split-like. They have kind of decreased. And the scleral inflammation is still there. But subsequently, as you move further in time, even this will subside. So this is a patient of viral and complete resolution of the condition after using antivirals and topical corticosteroids, but the patient is still on follow-up. This is another such case. It's not viral. It was immune-mediated scleritis. At entry, you'd see that it doesn't look like there's much of is swelling or thickening of the sclera. But when you do the OCT, if a normal thickness here should be less than 700 microns, here is about 1.08. So definitely it's thickened and abnormal architecture and all these dilated vessels. And when the patient is put on oral steroids and later was also on immunomodulators, you see that nearly, it's a month later, there is at least the architecture is getting stabilized. There is still some thickening and this will increase, this will get better. And this is down the line as you move for the same patient, maybe 2 or 3 months later. So coming quickly to the medical management, and this is a very good article that was published way back in 2008 by Professor John Kempen and group. They talked about step ladder pattern, and I'm going to elaborate on this in my next slide. All right, so the first line therapy for scleritis, especially the simpler ones, like I said, the diffuse anterior scleritis, has been described as oral non-steroidal anti-inflammatory medication, as well as plus minus topical steroids. Actually, topical steroids is not there. I've added that. So having said that, most of the time, maybe the kind of patients that come to us to institute, they just don't seem to respond to this alone. So most of the time I start this, get the investigations done, and when the investigations come back, typically I would have gone to second line. So let's assume that this worked for the patient and there may be some minor recurrences for this patient. You've investigated, of course, and nothing was there. And so you can tide over the recurrences with either local, just topical steroids or subconjunctival or transeptal, but you have to be very careful about these agents. And again, you can start the patient on oral NSAIDs for minor recurrences. Now, let's say that the patient improves, that's just great. But if there's a therapeutic failure, so that then we have to go on to second line treatment. Second line treatment is systemic steroids. But honestly, most of the patients that we see at maybe at institute, I don't know, Vanati and Dr. JB could tell, most of the patients are the ones we straight away start with second line. In our hands, first line is not there. We don't see the patients so early, I guess. So if you're very lucky, then the patient will just improve with systemic steroids dramatically. And they do improve dramatically. The trick is when you take off the systemic steroids and what happens. And you use it for a short enough while, adequate, and then the patient just goes into remission, and you can just maintain on either oral NSAIDs or topical NSAIDs and repeat this part as well. If there are minor recurrences, you can just go local therapy. Especially in COVID times, you don't want to use a whole lot of systemic therapy for these patients. So going local is better. Now, what if systemic steroids you've used and either it didn't work enough or it worked, but the minute you went on tapering, then there was therapeutic failure. Then you need to go to third line. And third line is nothing but our immunomodulators. And these are several drugs like methotrexate is what we use the most. MMF is also used. Dr. JB, I guess, uses it more than we do. And then you might, if it's necrotizing, some patients, we have to induce them on cyclophosphamide. And these are the other drugs that are also used, as well as sometimes a combination if one drug is not working that well. But honestly, we start off with systemic steroids, and many of our patients are also on methotrexate. And whenever they have minor recurrences, I usually treat them with a transeptal injection. Or if they're very severe, because our patients are slightly not affording, we're forced to induce them with cyclophosphamide. And if all this doesn't work, then we still have one more weapon, and that is fourth line. So fourth line includes the biologics and now the JAK inhibitors. There is some published studies on this latest one, but these are the biological agents of which many of us are using adalimumab as well as rituximab. The others I have no experience with, but these are the two agents that we've been using. In those recalcitrant agents where everything else has failed or is not adequate, or you cannot use some of these agents like say pediatric patient, you don't want to use too much of systemic steroids and methotrexate is not adequate, or you don't want to use cyclophosphamide because of its side effects of sterility and so on. So sometimes you will have to resort to fourth line of therapy. So I hope that was a very crowded slide. I hope I could make it clear. And this is one of our patients, which ultimately the patient is being followed up by Dr. JB because we tried our best to improve her. She just wouldn't get better and so dependent on oral steroids of at least 30 milligrams per day, despite.
This patient from Nellore, no?
That's right, yeah.
Yeah.
So finally we even gave her rituximab. I think we gave her 1 infusion or 2 infusions, and then Dr. JB took over, and I think he's been managing her since, and she somehow seems to be doing okay now, I guess. So that was an example of where we used rituximab for just probably the first or second patient that we used it, and that's why I was interested to talk about this case. So we talked about patch graft. Vanati talked about that, and these are some of the cases of patch grafts that we have done. Even the patch graft can undergo melt if you, like this example here, if you don't immunosuppress the patient. So the patient at least has to receive, if you need to do a patch graft, it means that we're really, really in big trouble. And you at least have to immunosuppress the patient, giving, typically we'll give pulse IVMP and as well as cyclophosphamide, and then take up the patient the same day or next day or as feasible based on the logistics and the workup of the patient. So here's one such patient where you can see that there's a very large area which is tectonically not stable. And what I've done is hand fashioned a piece of sclera after removing all the conjunctiva around it. And this patient was having necrotizing scleritis, but we couldn't detect anything systemic for the patient. And then after putting this, after initially fixing with some sutures, subsequently you can put in fibrin glue and stick the rest of it. So that's made things easier for us. You don't need to put a whole lot of sutures also, although here I have. And I've just trimmed it down. It's a very old video. And finally, on top of this, you cannot leave the scleral tissue bare because the edges will cause the tear film instability, and there'll be, as a consequence, there'll be multiple problems due to that. So what you can do is simply harvest conjunctiva as an autograft, and you can even put tenons on it. I mean, there's no problem in putting tenons on it actually, and harvest that and stick the conjunctiva with fibrin glue onto this area. So this patient actually did very, very well after the patch graft. Maybe we were lucky and we just used aggressive immunosuppression for this patient. She's been on regular follow-up, and the entire graft has literally sort of taken up by the eye. You can't even make out that there's a graft over there. But sometimes you don't have this luck, and this is another example of a patient who had a known case of vaginous granulomatosis or GPA, and we did a patch graft but came back with melting of the patch graft, and that was because the patient had stopped everything due to COVID times. So already Dr. Vanati has covered infections extensively. What I wanted to cover, if Dr. Sujit or Dr. Shah, if I'm going way over time, I can stop.
No, ma'am, we can continue.
Okay. So just to mention that the infectious scleritis roots can be exogenous, either by surgery or trauma. So I had typed in the chat box, these are the top two instances or history where, again, I would think first of infection. And the second is that there can be extension from adjacent infections, exactly as Dr. Vanati pointed out, like, for example, in fungal keratitis. And lastly, you can have endogenous, just like you have endogenous endophthalmitis, you can have septicemia and seeding of the bacteria or whatever organism in the sclera, it's an end organ. So in the sclera, it just gets seeded over there. It's a varying incidence based on literature, and we reported from our series almost 17.8 or 18% were infections. Actually, it was pretty high, but that's what we see at our series. And there's a patient who had pars plana vitrectomy, and you can see this white slough at the base of the vitrectomy ports. So it's not a case of surgically induced necrotizing scleritis, which was the initial diagnosis, but when you took scrapings from here, it turned out to be a case of nocardia scleritis, and that was only because of microbiology. Looking at it, you can't say what infection it is. And Dr. Vanati also mentioned that just about everything under the sun can cause infectious scleritis. So it's good that somebody asked the question about fungus. Fungus is not the commonest. Just because you have a history of trauma with vegetative matter doesn't mean that you get fungal infection. Although fungal infection is probably one of the single most common organism. But if you club all the bacteria together, you're almost 75% of the times you're going to hit bacteria, and only 25% of the times you're going to hit fungus. So therefore, it's better as empirical treatment, even if there's history of trauma with vegetative matter, to start the patient on empirical antibiotics first, if you don't have access to microbiology. Because the second problem with starting empirical antifungals is that it takes a very long time to respond, at least a week before you see response. So if you start antibiotics, you would expect a response in 48 hours. So that is the turnaround time because you have bactericidal agents. So that's another advantage of using antibacterial as empirical treatment. But at our institute, we don't believe in empirical treatment. We always take the patient for scleral biopsy. It could be the deroofing or deep scrapings from that area, because we know that taking in the office just a aspirate doesn't yield much. And there's so many instances where you missed the organism and lost time also. So right from when the patient comes in with what looks like infectious scleritis, the patient is scheduled maybe the same day or next day for a deep scraping. And I'm going to show you one such case. And just to complete, the list includes viruses, even acanthamoeba, as Vanati has already mentioned, as well as parasites. So this was a patient who had exactly the question that was asked about how do you do a biopsy of this nodule. So this patient had no history of trauma or any antecedent surgery, but presented with this scleral nodule, which obviously is infected. So here you don't need to wonder whether this is it infectious or immune-mediated, because it's pus-filled, it's obvious that this is a purulent lesion, and the patient did have severe pain. So what I'm trying to do is trying to excise the entire nodule in toto. Honestly, you don't have to do that, but because of the pathology background, just wanted the entire specimen. But anyway, so this specimen will be cut into half, and half of it will go to microbiology, cultured in various media, and the other half to pathology. And so of course, all of these cases, there is a lot of bleeding, and you just have to ignore that, or have a good assistant mop for you, or pour ringer lactate for you. But what I've missed out here in this video is that the bed is where you're more likely to be, the bed and the advancing edges is where you're more likely to get the organisms from. So the scrapings should be, after you excise the nodule, the scraping should also be taken from the bed. And leave that conjunctiva open. Do not put a scleral graft or anything like that, or don't cover it up, because it's just like principles of any abscess drainage, that you need to leave it open for access of the microorganism, access of the microbial, antimicrobial into that area, because sclera has a very poor penetration. So don't bother to put the conjunctiva back in place. You're going to impede the agents to reach that particular site. And I'm always amazed at, in spite of what looks like a very bloody surgery, and in spite of what I think that the patient will have pain and so on, I'm always amazed at how the pain goes down for the patient after you do scleral deroofing or scleral biopsy for infections. And that is simply because of, similar to the abscess principle, that you are getting rid of the infectious material for the patient. And the patient always even works as a little bit therapeutic also. You can irrigate this bed with either with betadine, you can keep flushing it with betadine. That takes care of both bacteria or fungus, or based on if you have some initial microbiology, you can use either antimicrobial or antifungal based if you have a clinical clue of what's happening. So I think I will end here, because this is a very long discussion on infection. Just to say that I was fortunate enough to write up on infectious scleritis, and the flow chart of how to differentiate between infectious and various other differential diagnoses, which is what is hidden here under these blocks, will be coming up in IGO. Coming up, the next issue will be entirely on ocular inflammation anyway, and scleritis. And in the infectious scleritis, you can go through this flow chart, which will help you sort of give you some steps on how to go further. So to conclude that immune-mediated is rare, and we've understood that oral steroids are necessary, but for initially treating the patient well, but you have to maintain them on immunomodulators. And the newer agents are there for the refractory cases. I always collaborate with the rheumatologist most of the time, unless for logistics, the patient just cannot go. And any surgical therapy that you plan, there has to be adequate or aggressive immunosuppression. And we also, just like Vanati mentioned, we have burnt our fingers with masquerades. So just watch out for those masquerades. She's mentioned already that you have myriad organisms causing infection. But if you have patients with trauma and previous surgery and debilitating systemic disease, think more likely that it may be infection rather than immune-mediated. Microbiological identification is paramount. If you don't do that, you just don't know what to do next. So you must have a good lab to help you with this. Surgical debridement works both for microbiology as well as a therapy. And then once you have these two things in place, you can start the appropriate microbiology. Thank you so much for listening to me for a very long presentation, and I apologize for that.
Thank you, ma'am. Thank you, ma'am, for that systematic approach and that stepladder management pattern. I think all of us have got a clear idea how to manage a case of scleritis. I think we'll go to the few questions to be asked to Dr. Anup first, and then we'll come back to the questions, ma'am.
Sure.
Dr. Mahir?
So, yeah, we also have with us today a well-renowned rheumatologist, Dr. Anup, to share with us his perspective in the management of scleritis. Dr. Anup did his postdoctoral fellowship in rheumatology and clinical immunology at CMC Vellore, and also his international fellowship in rheumatology from Norfolk and Norwich University Hospitals, UK. Currently, he's the medical director and chief rheumatologist at Dr. Anup's Rheumacare, West Hill, which is in Calicut, and a visiting consultant at Aster Mims Hospital, Calicut and Kottakkal. On behalf of Kozhikode Ophthalmic Society, I once again extend a hearty welcome to Dr. Anup. I request Dr. Dahlia to put forward to him certain common questions that we as ophthalmologists like to get answered from him regarding the management of associated systemic conditions in scleritis. Dr. Dahlia.
Thank you. Welcome, Dr. Anup. As all the panelists said that how important the systemic investigation is in the case of scleritis. So, and we need, in many cases, as 50% of do have a systemic cause, we need a rheumatologist's opinion on the same. So what we wanted to know is, what are the pre-investigations you do before starting an immunosuppressive treatment? Dr. Anup, are you there? Dr. Anup? So you have to unmute yourself.
Yeah. Can you hear me right now?
Yeah. So what are the tests you do before you start a patient on treatment immunosuppressive?
Yeah. First of all, I would like to thank all the organizers of this fantastic meeting, especially Dr. Sujit and Dr. Dali and Dr. Mellitus for that fantastic introduction. So I also used to get referrals from most of these ophthalmologists regarding the management of these immune-mediated inflammatory disorders. So coming to the investigations part, the first of all, I would like to mention that by default, when we see the cases like this, we always think that most of these infectious problems are actually sorted by this one as much as possible, sorted by ophthalmologists and getting most of the time a non-infectious problem. If you take TB out and let's just see some diseases which sometimes you just can't roll out 100% sometimes. So if you look at the this one the etiological point of view, predominantly what investigation we have to do depends upon the clinical scenario of the patient. So if it is scleritis, as everyone knows that immune-mediated causes of predominantly rheumatoid arthritis, relapsing polychondritis, retinitis granulomatous, or other anti-ulcerative vasculitis. So these are the most common systemic immune-mediated disorders. So most of the time, we try to dig out the history well and try to channelize the investigations according to the feature probability of the disease. So this one, Dr. Thomasina Murthy has fantastically has outlined what all the predominant investigations have to do in particular this immune-mediated disorders. So definitely we are going to do this one rheumatoid factor and especially if your rheumatoid arthritis is high on the card. And AMA and AMA is one of them, another important this one in order to ruling in a connective tissue disorder. And ANCA-associated vasculitis, definitely we need an ANCA. So I would like to tell you some of the pitfalls in interpreting these investigations. So rheumatoid factor, especially in case of rheumatoid arthritis, as everyone knows that if the patient doesn't have any clinical scenario, clinical features suggestive of rheumatoid, so RF factor can be positive in almost 13% of the population, in young population. That percentage actually increases when if you look at the age of 55, the percentage of rheumatoid factor positivity without an immune-mediated disorder in that particular patient will be somewhere around 40 to 50% of cases. So these are some important pitfalls while you coming into the interpreting these immuno-mediated serology, the immune-associated serology. So coming to the ANA also depends on this one. If the pretest probability of that particular disease is very high, ANA positivity has got an important role. So if you don't have this one ANA, if patient has got an ANA positivity, then definitely you have to go for an immunoblot. And immunoblot is depending upon which antigen specificity and depending upon the clinical scenario, whether you're suspecting lupus, whether you're suspecting MPTD, whether you're suspecting primary shopping syndrome. Depending upon that, you get that immunoblot profile positivity like. So then ANA also again you can have sometimes false positive ANA in patients also. So coming to the ANCA, if you are doing an ANCA, most likely the problem here in immunofluorescence test is that in ANA, the gold standard definitely is ANA immunofluorescence test, and also you can do IF test in ANCA, ANCA also. So what we used to do is that unless some of the main centers may have very experienced technicians or doctors who will be reading experts who have an expertise in reading IS in ANA and also in ANCA. But majority of labs usually don't have these expertise who's actually reading, giving a proper report in IS. So most of the time, I land up in asking for ELISA-based tests. So once if your ANCA is positive in IF, definitely you have to go for an ELISA-based anti-PR3, anti-MP ANCA and make sure that PR3 anti is positive. So another problem we used to get is that this one, what is the intensity of the titer? So I've seen some of the labs actually reporting ANCA values in 1 in 10 of intensity. So that is absolute absurd. You cannot give a report like 1 in 10 of ANCA, P-ANCA positivity like that. Minimum that intensity should be 1 in 80 or 1 in 150. So you actually don't want to give a report on positive report on 1 in 10 titer. That's absolute absurd. So this is a predominant problem we as rheumatologists face in interpreting these immune-mediated serology. So what is the titer? What is the actual pattern of the IS? What is the intensity of the IS? And what is the titer? Most important is the titer of the value of the ELISA-based test. So of IS sometimes. So these are the most important pitfalls and challenges we used to face while interpreting these immunoserology.
Thank you, sir. So, what are the blood parameters we have to monitor to look out for the side effects of these agents, the main ones at least?
Yeah, once you start on immunosuppressants, predominantly, my first choice would be either mycophenolate or methotrexate. So the thing is that methotrexate is the compliance of methotrexate will be much better than mycophenolate due to obvious reasons. So this one, we will be actually monitoring the common blood components, CBC, inflammatory markers, LFT, and creatinine. These are the most commonly done, very simple investigations we used to do for monitoring tests. So the problem is not actually due to, especially if you're dealing with methotrexate. The problem usually we face is that while selection of the patient, if the patient has got and metabolic syndrome like features like obesity, patient has got diabetes, patient has got fatty liver, these are the group of people we have to be really careful of while using methotrexate and other immunosuppressants, especially methotrexate, because rather than the drug itself, actually the metabolic syndrome will put the patient more riskier than the methotrexate on that particular patient. So most of the time, very simple investigations like complete blood count, CSR, CRP, LFT, and creatinine is usually sufficient for monitoring these patients.
How often you have to do this test? What's the
yeah, first visit we used to do first month and after 4 weeks. Then after that, most of the time 8 weeks to 12 weeks is the ideal time to keep on monitoring these patients. And I would like to keep a cutoff of 8 grams of hemoglobin and monitor for leukopenia and monitor for platelet count less than 1 lakh.
So about azoran, if you have a patient on azoran and he has got increased liver enzymes, what's the next step? Do you decrease the dose or you think of?
Yeah, that depends upon the patient's profile. The patient is very young fellow. Patient do not have any metabolic syndrome like patient is not on a diabetic patient. So in that particular case, definitely we can reduce the dose of the azathioprine and see whether it's increasing or not. But most of the time, if it is not reducing in another 1 week to 2 weeks, then definitely you have to stop the azathioprine And in that particular case, you have to opt for other immunosuppressants like tacrolimus, which is a little bit got a good safety profile in liver diseases.
I think we'll go back to the next case presentation, sir, and thank you so much, sir.
I have got one question. What is your experience of JAK inhibitor in rheumatology?
Okay.
I have used tofacitinib in a case of a necrotizing scleritis and a good response, and that paper is coming in IGO, the Journal of Ophthalmology.
Yeah. Actually, coming to JAK inhibitors, in my the most important game changer in clinical immunology is going to be JAK inhibitors in another 5 years. Most of the time, all these biologics will go to second year or third year or fourth year, and this is going to be the most important game changer in another 4 to 5 years. So till now, we have got two JAKs. One is tofacitinib and another one is baricitinib. Tofacitinib has got patients, 2 or 3 patients on refractory rheumatoid arthritis, but luckily these patients do not have any immune-mediated inflammatory eye disorder. So I do not have any experience on JAK use on autoimmune-associated inflammatory eye disorders till now.
Can I ask a question?
Yes, ma'am. Yes.
Dr. Anup, I have 2 questions for you.
Yeah, sorry.
One is you need to answer. The second one is you don't need to answer. The one you don't need to answer is, why are the names of these biologicals and JAK inhibitors so difficult to pronounce?
Yeah.
And my question for you is that what is the role of the HLA testing? Do you attribute a lot of significance to it for scleritis patients?
Can you repeat the question once again?
HLA testing.
Okay, so HLA testing. HLA-B27, the most commonest HLA associations we look into is HLA-B27 and HLA-B5B51. So HLA-B52 we usually don't do. HLA-B27, as everyone knows, is spondyloarthritis. All patients coming with anterior uveitis or peripheral uveitis, I usually regularly used to do HLA-B27 by PCR method. Because we have got a lot of labs doing by flow cytometry, but I think personally believe, and there is reports like PCR is much more sensitive and specific. Another thing is that HLA-B5 and B51, there are a lot of reports saying that almost especially in Bishop's syndrome, almost the odds of getting a Bishop's disease if patient is possibly for HLA-B5, B51 is almost 5.6. So, once I was attending a EULA conference, and the very big expert on Bishop's disease, that is Hassan Yatiki, was actually telling that they have got almost 70 to 80% of positivity rate of HLA-B5, B51. But unfortunately, we have got that cohort of almost 75 cases from South India, Bishop's syndrome. But our HLA-B5, B51 positivity rate is much less due to unknown disease. We don't know exactly. And coming to HLA-B52, there are certain reports that HLA-B52 can be a small association, positive association has been seen in vascular Bichet and also in Pediatric Scleritis.
Thank you.
Thank you, sir.
Thank
I
you.
think we'll go to the case presentation.
Thank you, Dr. Anup, for your valuable inputs. We have a challenging case-based scenario for which we would like the valuable inputs from all our speakers. I invite Dr. Avungshi to present her case. Dr. Avungshi is currently doing her fellowship in Pediatric Ophthalmology and Strabismus at Comtrust Eye Hospital, Calicut. Dr. Avungshi.
Hello, good evening, everyone. I would like to thank my mentor, Dr. Laila Mohan, for giving me this opportunity, and KOS, Dr. Jiresh Madam, Dr. Shahid, and Dr. Mihesha sir. We had a very interesting case a couple of weeks back. A 28-year-old male who had a complaint of swelling, not just in the left thigh, since the past 10 years. He says that recently it has been gradually increasing in size. He has a history of swimming in stagnant water, and there is complaint of occasional watering and redness, but he has never sought any ophthalmological consultation for the same. He hasn't undergone any surgical intervention. He hasn't taken any medication for that, and he has no other systemic illness, no history of trauma, no history of epistaxis. On examination, his best corrected visual acuity was 6/6 in both eyes. Extraocular movement in right eye it was full, and in left eye it showed abduction and elevation and adduction of -1 limitation. Intraocular pressure in both eyes was normal, and a right eye anterior segment examination was within normal limits. Left eye, however, there was a brownish black 5 mm into 5 mm into 3 mm swelling from 9 to 11 o'clock position nasally. About 1 to 2, it was located around 1 to 2 mm away from the limbus, and it was covered by a very thin layer of conjunctiva. There was heavy vascularization seen, especially on the nasal side of the swelling, with subconjunctival hemorrhage. Surrounding vessels appeared dilated and tortuous, and there were multiple white pinhead-sized round deposits seen on the surface of the swelling.
Okay. Rhinosporidisis.
So cycloplegic refraction and fundus examination were done, which was within normal limits. And we also did an ASOCT just to make sure that it was not a solid mass, and it just showed ectatic sclera with slight thinning of near the limbus area. Based on clinical examination, we came to a clinical diagnosis of ocular rhinosporidiosis induced serial melt with staphyloma left eye, and the patient underwent incisional biopsy just last Tuesday, and the sample was sent for a histopathological examination. So this was the histopathological slides that the pathologist sent to us. So there were a number of double-wall cyst sporangia which were releasing the with bearing sporoblasts in different stages of the rhinosporidiosis. And now we're planning to go ahead with excision next week, with excision of the conjunctiva with around 2 mm normal conjunctiva and cauterization and scleral patch graft. Is there anything else that we can do differently for this patient other than what we're planning?
You know that the first series of ocular rhinosporidiosis, it's a ocular sporidiosis, has been described by Kuriakose from Kerala.
Yes.
The Kuriakose from Kerala in British Journal of Ophthalmology. And the Somshila can be tell that one. I think this is the definitive treatment for this. The medicine doesn't work. And the diagnostic point is the granules which you see in the sclerostaphyloma. Surrounding it, small granules will be seeing.
Yes.
That was the diagnostic pointer.
So is it like when I was going through the literature, I've seen that, sir, you have also had similar experience, and you have also made a publication. There were 3 steps of a management plan that was said. First of all, was just a conjunctival flap that could be placed on top of the ectatic area. The second one was scleral patch graft or amniotic graft, and the other one was corneal graft. So in our case, we are planning a scleral patch graft, but they say the chances of recurrence in scleral patch graft is very high.
It's very high. Yeah. Can I say something?
Yes, sure, ma'am.
Yeah. So this is exactly similar to the case which I had managed a few years ago. So the moment you showed the picture, or the first picture itself, it was very conclusive that it was ocular sporidiosis Yeah, and a very close-up picture will show those characteristics sporangia which are on the conjunctiva here. And this is how it classically presents in an ocular presentation, where the underlying sclera gets sort of melted away here. And you have a ciliary staphylomas kind of a picture which is having. The case which I managed was much larger than the area of scleral involvement was much larger and much extensive than what you're showing here. So yours seems to be more contained to a particular area here. So I managed a similar young individual here. Again, the history of swimming in stagnant pools is also something which is characteristically associated with rhinosporidiosis here. And you have particular areas, as sir mentioned, which are endemic in India here. And I would go ahead and do a patch graft, a tectonic patch graft here. I have largely moved to doing using corneal tissue itself for doing patches over the sclera itself. So I would, the ease is because we do get, most of us have shifted to in situ excisions, corneoscleral in situ, and getting sclera is, you have to send in a special request to our eye bank. So you always have therapeutic grade corneal tissue available to us. It's easy to fashion out a patch graft with a corneal tissue here. And I still use, and this is something which I picked up from Professor Donald Tan when I did my fellowship under him. And I always prefer to use because of the better resilience strength. It is easy for handling, easy for suturing, and you can get large sized corneal tissue as well in these cases where you need larger ones. So you could go ahead and use your corneal tissue and do a patch graft for this, and always remember to cover it up with conjunctiva and do a broad excision conjunctiva, removing most of the conjunctiva in the surrounding region, and do a conjunctival autograft in that particular region. Always counsel your patient that there might be a risk of postoperative retinal detachments in these cases, because you see the entire the globe complex there, the external coat of the globe going right into up to the retina is probably not going to be healthy over here. You might probably want to do a prophylactic cryo all around as well when you're suturing these patients. There would be intravitreal bleeds when you're doing these particular cases, some amount of astigmatism as well. And these patients tend to develop cataracts subsequently here. So you will have him coming back to you for a cataract surgery subsequently, when the kind of incision placements is something which you would also look at, association of secondary glaucoma. I'm very sorry I could not add on my picture of this particular patient, but I had a patient similar with ocular rhinosporidiosis, and I had to do a very large scleral graft for him here. The region, he was initially contained well, but the rise in pressure still goes on. When he came back for his third or fourth follow-up, the region had become a little more ectatic, though the patch graft was holding well. His pressures were managed on anti-glaucoma medications here. I did a cataract surgery, but I had to do an SICS for him subsequently. And he still does well with about a 618 or a 612 vision when he last came for his follow-up almost a year ago, I think. So I think you can go ahead, because the lump always stays there. And that is what they usually complain of. And their vision is actually good for these patients.
And madam, right now, because of this COVID situation, getting
Yeah, you can
corneal,
hold on. Yeah, you can hold on.
getting cornea, cornea, it's a little bit difficult. We have the short sclera.
If you do have sclera stored in your eye bank, then yes, you can. Yeah.
Okay. The only thing is that because of its chances of recurrence, like if it.
As I said, do a large conjunctival excision there, because
Okay.
the primary infection usually starts from the conjunctiva here. So you are seeing active conjunctival spores on top of these patients here. So do put them on a long-term medical management as well.
Yes, we're planning on that soon.
Yes. So you do need to keep them on, work them up for a dapsone management there, and take them on.
Is it all? Leila ma'am wants to thank Dr. Vanati ma'am for that wonderful input. Leila ma'am wanted to ask JB sir, like, how far does dapsone help in long-term prevention of recurrence?
I'm not in favor of dapsone. I give the surgical excision is enough.
Is it necessary to add adjunctive therapy with dapsone?
I have not given dapsone to any of my rhinosporosis case. They do well with surgical excision.
Okay. Thank you, sir. And Leila madam wanted to know, have you started harvesting donor cornea during these COVID times? Leila ma'am, you can talk, ma'am. You've been unmuted. Leila ma'am, can you?
Yeah. Yes. Thank you, sir. I saw Debbie sir's paper with the patch graft. Actually, that is what we were planning. But then I found a lot of papers with an add-on dapsone to prevent recurrence. Can you hear me, Dahlia?
Yes, ma'am. You're very clear.
Very clear.
Yeah, we have stored sclera, and just wanted to know not about this case. Have you all started harvesting donor cornea, madam? So, Dr. Somashila?
Yes, ma'am, we have. We have to make sure that the patients have, the donors have COVID test with them. And this is from, most of them are just the hospital retrievals, not the voluntary donation. And we have to make sure that it's from non-COVID hospital. So it's we have up to just 10 to 15% of our usual collection.
Okay. It was a wonderful discussion. Infectious, non-infectious, medical and surgical management. Thank you so much.
Thank you very much for giving me the opportunity.
Thank you.
Are there any questions in the YouTube? Please, sir. I think we'll conclude. Thank you all for that very interactive discussion and very useful. Just to conclude, I would say that as JB sir pointed out, that sclera is a cause of red eye, which is not just vision threatening, but life threatening also. So we have to have an effective way to approach scleritis with proper investigations and management. And wherever required, especially necrotizing scleritis, we may have to involve a rheumatologist also to rule out the systemic causes. As rightly pointed out, 50% of cases may have a systemic cause. So I hope this session was useful to all to see the next case of scleritis with a more systematic and a stepwise approach. Thank you all.
Thank you very much.
Thank you, ma'am. Thank you, sir.
Thank you.
Call Dr. Narupama to say the vote of thanks.
Good evening. Able to hear me?
Yes.
On behalf of Kozhikode Ophthalmic Society and the Scientific Committee, it's my privilege to propose a vote of thanks on this occasion. My heart fills with lots of gratitude and respect for our distinguished guest speakers, Dr. Jyotirmay Biswas, Dr. Vanati, Dr. Somashila Murthy, and Dr. Anu, for sparing their invaluable time to enlighten us and enhance our understanding pertaining to scleritis. Thank you all. I thank all the participants and presenters for the interest shown. Last but not the least, I thank Team AICE Pharma for the brochure and platform support lended. Thanks to you all once again. Thank you.
Thank you, ma'am.
Thank you.
Thank you.
Thank you.
Dr. Shujit.
Thank you all.
Thank you, sir.
Thank you.
Thank you. All safe.
I
Stay
think
safe.
we'll conclude the session. Good night, all.
Night, sir.
Thank you.
Good
Good
night.
night.
Good night.
Good night, all of you.
Good night, sir. Good night.